Who?
Okay.
Can you hear us, Ben?
All right. Can you hear us?
Yes,
Can you
finally.
see
Thank
the
you.
blue slides? Can you see the blue slides?
See the blue slides.
Awesome. All right, great. Okay. I'm going to get my phone so I have a reliable clock.
You should be having a band or something.
I'm delighted you can.
Hey.
So, thank you.
Yeah. How are you feeling doing that? Oh, good.
Yeah, that's great. I don't think it's readable today. So that's good.
No, I couldn't tell what you had. Thankfully, yeah.
If I come on Friday.
Great. All right. By my reliable phone, it is 1:01, so we should get started. All right, thank you very much, everyone. Thanks for coming. Tēnā koutou katoa. Welcome to this week's seminar. I'm Josephine Johnston, Associate Professor here in the Bioethics Centre. I'm today's chair. But anyone is welcome to offer to be chair anytime that they want to for a subsequent seminar. Our seminars run from 1 to 2 every Monday while we are in session at the university. We've got lots of speakers from all over the world and also right here in our own Bioethics Centre. Just people on Zoom, just keep yourself muted or I'll mute you if you unmute at the wrong moment. We're going to go from 1 to 2. There'll be time for questions and discussion. So if you're in the room, please just raise your actual hand. I'll keep a list and people online can raise their virtual hand or they can put a question in the chat and we will come to them as in the question session. So now I'll introduce our speaker. So it's a pleasure to welcome my colleague here in the department, Dr. Simon Walker. Simon is a philosopher who is senior lecturer here in the Bioethics Centre and does a lot of work with our medical students. His current research looks at the link between values and suffering, drawing on many different sources, including clinical experience, ancient and modern philosophy and literature. And today his talk, I think quite provocatively for someone in the Bioethics Centre, is titled, "Does Ethics Education Prepare Students for Early Clinical Practice?" So, Simon.
Thanks, Josie. Kia ora koutou. Thanks everyone for attending this session. The question I'm addressing, as Josie has just said, is does ethics education, that is teaching students about ethics, how to be ethical, does it prepare them, the students, for early clinical practice? And as Josie's already just signalled, I do have a personal and professional stake in the answer to this question. It would be very much to my advantage if we can say yes. And with that, I think this is true for many of my colleagues here at the centre. I have been here involved with the teaching for around 15 years, and I'm currently convening the ethics modules for 3 of our 4 campuses at Otago Medical School, and also in several of the healthcare professional programs. So that's my personal stake, a little bit of reflexivity for you all. Having said all that, I do think I can sincerely say I am interested in the answer and want to know. And over the time that I've been here working with my colleagues, we are routinely asking ourselves why we do what we do and have made changes in that time to improve things. And if through this inquiry, and I'll be very interested in the comments at the end after I've had what I have to say, if we find ways to improve, we are open to change. What I will be doing, also to temper your expectations, is offering a commentary on the findings of a qualitative study that was undertaken just a few years ago by a colleague and student of mine, Dr. Sinead Donnelly. And Sinead will be presenting in a couple of weeks actually to this forum on a related topic. I'll tell you more about the study that she did soon that I was supervising. But yeah, so what I'll be doing is giving some reflections on what we found out on this qualitative study, looking at the ethical issues that doctors were encountering straight out of medical school in their first and second year of practice. Okay, so here's an outline of how I'll structure this talk. I'm going to say a few things about what we already know about the impact of ethics teaching, but also comment on some questions that raises for us. I'll talk about the empirical study that Sinead ran. In discussing the findings of that study, I will detail how they perceived ethics and the ethical situations, challenges they encountered, how they reflected on their undergraduate ethics teaching, how well it prepared them, and then finally I'll close with some thoughts on what we can do to prepare students for early clinical practice through our ethics teaching. Now, I actually, in building this talk, I thought that's probably a better title in terms of what I'll be offering today as a commentary on how ethics education might prepare students. How well we're actually doing it is quite hard to say, and I think it'll be obvious to most of you. The comments of a small number of doctors won't settle the matter at all, or my theories around that. But hopefully it'll give us things to think about and to work on. So let's talk then about the impact of ethics teaching, what we know. Well, currently ethics is taught in medical schools all around the world. It is fairly well baked into accreditation standards. So there's an expectation that medical schools teach ethics. Assessing the effectiveness or the impact of that teaching is very difficult. And I'm quoting here from a 2007 paper by Alistair Campbell and two of his colleagues at the time from a university in Singapore. Alistair's a former director of this bioethics centre actually, but he, in this paper with his colleagues, noted just how difficult it is to actually predict how a person will behave in the future, irrespective of how much we try to influence them through a training program. And partly based on what they discuss in this paper and from my own reflections on this, it seems to me that in trying to evaluate the impact of any ethics teaching, we have to first standardize what is taught and the way that it's taught. And then we also have to define what we mean by preparedness. What are we actually thinking would be success? And I'm going to comment a little bit on a couple of slides on that last question too. But if we can't agree on all of those things or standardize them, it's very difficult to compare studies. Again, having said that, I will offer some findings from a systematic review shortly. Okay, and there is, I can add to that, some agreement about at least what the content, international agreement about what the content of ethics curricula should include. There's an updated consensus statement from 2010 by Storat and a long list of colleagues. And also there's quite a lot of consensus around the best way to teach ethics, at least in theory. Most will agree that it needs to be clinically relevant, that we're not training specialist ethicists, much less philosophers. We need to be working back from the challenges that are facing clinicians. There is a need for the teaching to be horizontally and vertically integrated. That means it needs to fit with the stage of learning of the students, what else is happening in their course, and also that the ideas are built upon as they work their way forward and reflected in the light of experience. They're traveling upwards on this spiral of learning. Small group discussion is generally recognized as the best way to learn about ethics, certainly early on, and where possible, co-teaching is encouraged, so you have a clinician who can speak firsthand about what the situation's like, what it's like to be challenged and the way that the ethical challenges present themselves, and then to have the ethicists drawing the connections together. Okay, and just as some further from that study by Campbell et al., they offered this nice little triangle listing learning outcomes that an ethics curricula should include, along with some assessment methods that could be used to pick up on those particular outcomes. And you can see that they work from a basic level of knowledge that's required that can be assessed through MCQs and essays and things, but then working towards application and practice. But they note that this knowledge development is not just ideas, it's not just the impartation of information, it is a kind of formation of the students where there is aspects of character involved in the ability to integrate and to act responsibly to the situations, responsibly and creatively, I guess, or at least in the moment that is required. I'm intrigued, and if there's any education specialists with us today, I'd love you to help me with this later. I'm intrigued about why these diagrams are often take the form of a pyramid or a triangle, and we have quite a lot of knowledge at the bottom, and then it somehow arrives at a point, which is, I guess, the moment of action, some sort of integrative thing, I guess. But yeah, we might come back to that. All right. So I'd say a couple of things about how we might think about the goal of ethics education, what it would mean to be prepared. And here I'm drawing from a study by Caulfield and colleagues, 2021 study, in which they surveyed just under 500, well, they had 500 participants in a survey of newly graduated doctors, asking them to report on their level of confidence or preparedness in responding to ethical issues. They did this by presenting the participants with three scenarios of increasing ethical complexity. Their finding was that the respondents were more confident in dealing with the more complex cases. And they inferred from this that this was because they weren't aware of the ways in which the situations were ethically complex. And they caution on the basis of this that we shouldn't think of preparedness simply in terms of the ability to make or confidence in making a difficult decision. Awareness and some discomfort may actually be what we're aiming for. And that could mean that because you're not able to manage it well, you recognize your own need of help, you would refer or call in someone else. So I'm just going to offer this as a sort of provisional way of thinking about preparedness. A doctor would be well prepared if they can both recognize the challenge that is presented and have some means of negotiating or managing it. Managing it's a term that Caulfield, that might be a different thing. Anyway, that is used. And conversely, if somebody's unprepared, well, they may either they be oblivious and therefore act dangerously, or they might be quite aware but overwhelmed by that circumstance. And just to give you some sense of where we are at with empirical studies on this matter of how well prepared students are, what ethics education is doing for students. There was a systematic review undertaken by Anderson and colleagues in 2022. They gathered together all of the empirical studies looking at the impact of ethics education that they could find. They rated them all in terms of their quality. It was a little bit, in my assessment, all over the place, and it was such variability between the types of teaching that was happening and so on, and the outcomes that were measured. But they did conclude that this ethics teaching could be helpful for these students by drawing their attention to ethical problems that they've not been previously aware of. And they also offered this definition of dealing with ethical problems as an ability to reason about what is right and wrong, what is right and in the patient's best interest, along with making decisions about what needs to be done. I don't think there's anything too surprising or controversial in that. Okay, so what did we do? Well, Sinead was recruited to help with the 5th year ethics class on end-of-life care at our Wellington campus. And just, Sinead could speak for herself, but my account of this experience was that after the session, she was prompted to think about what in fact are the challenges that are confronting doctors once they've graduated. So that might inform the design of these kinds of classes. So she undertook a Master's in Medical Science with us here at the Bioethics Centre. I was one of the supervisors for that. And she interviewed 13 of these doctors on 4 occasions each, so there was a progression for them. And those interviews were structured around, there were these 4 questions listed there. What ethical issues had they encountered? How were they doing in managing these issues? What support was available to them? And she explicitly asked them how well the undergraduate ethics teaching had prepared them. Now, again, reflexivity on behalf of Sinead. She doesn't have the same investment in our ethics teaching as I do. And she is also has an interest in understanding how ethics compares to what we just ordinarily call good clinical practice, what we being, say, what clinicians would describe as good practice, and whether and how we can actually separate ethics from good practice. In keeping with that, she didn't offer a definition of ethics in undertaking interviews, but asked or invited the participants to talk about it in their own terms. Okay, so how did these participants describe ethics? Well, in technical terms, I would say they viewed it as concerned with normative problems that required deliberation, or more precisely in the words of one of them, umming and ahhing about what you should or should not do. So the umming and ahhing is the deliberation, the should and the shouldn't is the normative bit. A number of them linked ethics directly with values, and this was intriguing to me, they do distinguish it in some sense from either medical or clinical or academic or also scientific thinking. And this quote I find particularly nice. An ethical problem makes you feel a little bit uncomfortable. Maybe that's a reflection of when something has an ethical or a values flavor to it. It's when it's not easy to shrug off and it's impacted you in a very human way, rather than as an academic or in a medical way. It has this impact on you as a person. Those are the things you take home. Those are the things that keep you awake at night. It's not about the medications. It's, have I done right by that person? And it brings in this whole element of what it means to be human and what it means to be alive. So this actually captures what a number of philosophers have said about ethics and linking ethics to, well, firstly, the reflective structure of our agency, the way that we seem compelled almost to, or we can't escape thinking about how we are and why we do what we do, and that this in turn is linked to how we feel about ourselves and what we understand as being human, humanity. Ethical problems that they encountered, there was a range, and we were able to cluster or group the findings into the following themes: care and decisions based on a patient's age, issues around prognostication, just caring for a person that was dying was described in ethical terms, managing family requests, the resuscitation decision status was an issue, being on their own in either a rural hospital environment or out of hours was also a common cause of ethical challenge for these students, participants. And a connecting thread throughout was this idea of being responsible for high stakes decisions. I'll read you another quote from one to illustrate how this could go, and this one particularly relates to resuscitation status. One of the things that has been consistently coming up, especially in the last couple of weeks, is the goals of care. So the issue was there, we asked for an opinion, he expressed it, and then we just decided we weren't going to do it anyway. So what was the point of asking for an opinion or even go anywhere near the resuscitation? Why even bring up resuscitation if we weren't going to do it? We don't offer heart transplants to people that clearly we were never going to do heart transplants on, but we offer resuscitation to people that we clearly don't think are going to benefit from it. So that was an example of an ethical challenge that one of the participants talked about it as it's coming up quite often. Now, there are studies that specifically look at the types of ethical challenges that junior doctors or recently graduated doctors encounter. And in particular, I could refer to this one by McDougall and Sokol from 2008. And they noted that this particular situation of these younger doctors within the hierarchy changes the nature of the ethical challenge as compared to how we often talk about it in an environment like this or academically. Here's a couple more quotes. I've found that the ethical issues around junior staff running the hospital, having a lot of responsibility, particularly overnight. So you end up taking a lot of responsibility for having difficult conversations with them. And then for some, this was challenging to the extent that it made them question their ability to carry on in practice. Some of them talked about not wanting to come into clinic the next day, not being able to confront the situation, just feeling really profoundly undermined One of them said, "This run's been horrendous. It's resulted in me not wanting to do clinical medicine. I find it so frustrating. It's a run where there's a lot of responsibility put on junior staff because the bosses are not around for." So if you haven't picked this up, the PTY1, but that's obviously a reference to a year one graduate, and we just coded them by letter after that, just to preserve anonymity. So there's something you may have noticed already, I alluded to it, that whilst the kinds of problems they described, the way that they talked about it fits with the definition of ethics that we use in our ethics teaching, and the way a lot of people, both in academia and in common language, would discuss ethics. There is a difference in that many of these problems aren't conceptually difficult, well, not very difficult. They're not the sort of situations that you would see referred to a clinical ethics consultation service. And a number of them, there is a sense that we knew what the right thing to do was, well, the participants knew, but the problem was that thing wasn't being done, or that it was maybe beyond the participants' capacity to manage. So I'm going to return to that later when I comment on the patients. Sinead was particularly concerned to know what help the participants were getting, and as I mentioned, they were interviewed over 4 stages, so they could reflect on how did you go working through that challenge, what made it easier or better for you, helped you, conversely, what made it harder. And a significant or recurring factor was the response of senior colleagues, where the senior colleagues would support them, acknowledge the challenge was a challenge, and perhaps give them an opportunity to talk about it and to reflect after the event. So thinking about why did that happen, or it could be just as simple as acknowledging that, yes, that was hard, what we had to do there. This is a hard thing to go through. On the other hand, if, and this happened sadly, if the participant felt that they weren't, the difficulties weren't being acknowledged, or if they were felt made to feel inadequate or not able to do the job, this was really undermining for them. And similarly, if there was just an expectation you carry on, there's no opportunity to stop and think about it. Now those findings have significant implications for what we could do to support junior doctors now, and that's motivated Sinead to carry on this work, and she's been investigating this in the PhD project, which she will, all going well, have an opportunity to present on soon. But I'm concerned today, as you picked up, hopefully, that with what all this means for our undergraduate ethics teaching, so that's what I was focusing on next. So we did, as I mentioned, specifically ask the participants, how well did your undergraduate teaching prepare you? And here are a couple of quotes and just an overview. Broadly speaking, they did describe their undergraduate ethics teaching in positive terms. Good. Several commented, however, on the difference between having a discussion about an ethical situation or challenge question in a classroom environment and actually being there, being responsible for the decision. So these are a couple of particularly positive quotes. I think the ethics we do in medical school is great because it just exercises that part of your brain. There's that kind of idea of a different way of thinking, which is intriguing to me. And then it becomes more and more subconscious as the more and more you do it. So I'm continuing to learn that all this is more real than it was in the classroom. I think this participant is picking up that just the realness of all that thing, the stuff that was covered in undergraduate level. Another participant said it was good, it prepared us well. And then the qualification, a lot of the ethics we do is academic. It provides a good framework for ways of thinking and understanding your own responses and other people's responses to a problem. But all applying that, feeling it and living it, that's something that you can only do. And here's a slightly less positive, it's not negative, but it emphasizes this, or it expresses a perceived disconnect between the undergraduate teaching and practice by way of this idea that ethics teaching is focused on dilemmas. And as I've signaled, a lot of these situations weren't exactly about dilemmas. So this participant recalled, and I think they're referring to an informed consent class from secondary, presuming. I could have said, I can give details of the participants, their demographics and so on, but 11 of them were graduates of University of Otago Medical School, and 2 were from Auckland. So hence my supposition that this is an Otago graduate. We have a class in which we put to them a case where there's a patient who's a Jehovah's Witness, or apparently is a Jehovah's Witness. What should we do? Should we give the blood transfusion or perform a hysterectomy? It's a good class to divide the room and get some debate, and it tends to be memorable. But what this participant's remarking on was like, that's how ethics seemed to me, at least in the preclinical years. But in practice, we had this situation with the Jehovah's Witness refusing blood transfusions, and we just dealt with it in other ways. Circumvented the ethical problem. So I do think we have to confront that. It's a perception that one hears of from time to time, that academic ethics is all dilemma driven. In practice, it's not necessarily like that. And actually, one of our participants offered what I would suggest is at least a partial response to the thought by noting that in ethics training, and particularly in the assignments we asked them to do, there does tend to be a question that needs to be explored, like should this surgery be offered or not to this particular patient, and so on and so forth. And this participant notes that actually for the health surgeon, that's another name for a PGY 102, they're often not making those kinds of decisions. But nevertheless, this participant could see a value in that kind of thinking about the harder cases as it helped them to understand the situations that they were confronted by. Okay. So just to summarize the key points from the study before I move to my final section, which will be thinking about the implications. Yeah, so as I've signaled, these young doctors do encounter ethical challenges. They're often about making high-stakes decisions in emotionally difficult circumstances. Support or acknowledgement from colleagues, senior colleagues, is particularly important to them, and also the opportunity to reflect on what is happening. Undergraduate ethics education viewed positively, but as different from what is happening in practice. And just building on that last point, I don't think that we can ever prepare students such that the ethical problem wouldn't be there for them. It's always going to be hard in some ways. Okay, so moving on, what can we do? How might undergraduate ethics teaching prepare students for early clinical practice? Well, I've got 3 suggestions points which we can discuss. The first is, I think you can be instilling an ethical awareness or sensitivity. And notice that to have identified an ethical problem presupposes some awareness of what the values are that are in play, or the standards. Thinking specifically again about that example involving Jehovah's Witness, it was striking to me that whilst the participant thought there was no big ethical dilemma to manage, there was a presumption that informed consent was important and that we should be taking the patient's consent seriously. So there's a background of ethical understanding that's informed their response to that situation. And I would say I would rather our graduates are troubled by standards not being met as opposed to being oblivious. So there's a role there for teaching values and standards just to enable this recognition. Okay, that's point 1. 2, I think we can be contributing to the development of an informed practice of critical reflection, both for the individual, but also corporately, whether that's amongst the peer group or within the whole team environment, where they know the standards that are relevant, they are responsive to how well those are being met in the situation, and have a practice of thinking about what they're doing and why they're doing it, which is much of what is happening in an ethics teaching session. And it's good, I think, if they can do this together. So I do talk to graduates, those that I've kept in contact with, and I've noticed that some of those that do seem to manage better these early years, they've got good connections with their peer group, and they have routines whereby they come together. It might be after a shift, they might eat together, they'll talk about what's happened. That's helpful for them. And obviously for the harder cases, we need the senior colleagues to be there to advise on exactly why such and such has happened and what it all means. Now, in thinking about this aspect of our findings, I've had a look into the literature on reflective practice. Again, if there's anyone here who specializes in educational theory, I'm sure you could help at this point. I found that this is widely discussed in application to healthcare, but also other contexts. It is something that's emerged, I think, first in theory of education. There are many definitions around, so many that I wasn't prepared to offer one because I'm not sure which would best capture the current consensus. It seems to me that for the participants of our study, what they understood by this active reflection was firstly articulating what it is that's troubling, and then part of that, finding some kind of solidarity because somebody else says, yes, that's appropriate, that you would feel that way. Then exploring the reasons for either what was done or their reactions to it. So trying to come to some understanding. And then being reassured that they're doing okay and that there's a way forward. So that looks to me like reflection is an integrative process, which is enabling us to restore. I think all of us can do this at times. Well, and probably should do it. Where we're restoring or maintaining our sense of agency. We're asking, who am I in these situations? Why am I doing this? Why do I do that? Is all this okay? And there was one author I did find in the literature on reflection, Schon, who seems quite influential, and in a 1983 article distinguished between reflection on action and reflection in action. So reflection on action is when we look back at something we've done to make sense of it. But reflection in action is a process whereby we're pulling together a whole bunch of ideas or thoughts or knowledge in response to the dynamic situation we're in. And so it's a creative act of sorts of transformative, whereby we're actually we're learning as we go through this active reflection. Now that if that's what is meant by reflection, then I think that fits with the earlier point that I noted about ethics teaching needing to be about more than simply the impartation of knowledge, that we are actually involved in a formative process, that it is ethical competency. It's not something we can consider simply learned in a classroom. It has to be learned through practice, and perhaps to Camberley Tools triangle, we need to add this notion of reflection somehow. I made an attempt. And just in closing, this is my last slide. My final thought is just in thinking about all of this, to me, it highlights the importance of an integrated curriculum. And once again, there is a perception around that ethics is somehow distinct from other bits of a curriculum or living in its own space. And that can be a problem if it means clinicians or students bracket ethics as something that it's not part of their main curriculum. It's something they can do if they're interested, if they come around to, or if they're compelled to through assessment. And in 2015, this author, Zula Etta, commented that we need to translate the scholarship of medical ethics into good ethical medical practice by paying closer attention to the everyday ethics. That's what she referred to, and the goal of the relief of suffering. Now, there's probably room to argue with her paper in some ways, but I do see the point in that if it is that we need to understand ethics as part of what doctors are doing all the time, and seeing the connections between other things that they're learning and articulating those more clearly. And when I think about our teaching, I notice within our curriculum, we have early professional experience, professional development, this burgeoning or perhaps nascent program on professional collaborative practice. I've got my acronyms a bit wrong there, sorry. And also the whole concept of quality and safety. I think that there are overlapping goals between these areas of the curriculum, which we need to articulate both for ourselves and for our students, so we can see how the connections are happening in practice. Okay, I'll stop there. Thank you very much for your attention.
Thank you, Simon. Is it all right to stop the share?
Yeah.
Because I can do it. That way we can see all of our participants, and I'm just going to give people a second. If you want to put your hand up, I can see Ben's hand is already raised, but other people should also feel free to put themselves in the queue. And we've got, just give me 1 sec here while I note these people down. Okay, and I'll start with the 2 people online. So first Ben and then Monique, and then I think we've got enough time that we can just ask a question and you can answer, and
Yeah,
then we can go.
no
And if we run out of time, I'll start aggregating questions.
That sounds great. Thank you.
So go ahead.
I mean, that was great. Couple of thoughts. First is the question of what was broken. I had no ethics training at medical school. You could argue I was completely unethical until I got trained by you guys, but I'm not sure that's the case. So I think there's an interesting thing about what is it that it added to what was present before, which I think relates to my other thought, which is around the curriculum, in my view, is the sum of what we write down that we teach and the whole apprenticeship model. So in terms of the TPAs that I'm currently doing, there's a whole lot of learning they've done about resource allocation from their GPs who only had 15-minute consultations and talked about how they made their decision, for example, about resource allocation. So I think there is a whole load of teaching and learning around ethics, which is part of clinical practice anyway. And so I think teasing those 2 out is quite an interesting dilemma.
Yes, thanks, Ben. I think there'd be a number of things we can say in response to that. I don't disagree in terms of the importance of modelling and of how we learn our behaviours through watching others. So one of a former student of mine who's now in 50 years out of med school and going into physician training with the College of in the medicine registrar program, and said that the first few years was just pattern recognition, figuring out what is everyone doing and what do I do in this situation, and there wasn't a lot of thinking about what's actually the solution. I suppose the counterpoint in terms of what was missing before was that whether or not you turned into a good doctor depends on one hand on your own conscience and what you brought to that, but also on who you were modelling yourself after. And by teaching about values and standards, we are at least establishing a line and also encouraging a discourse amongst this cohort where they can talk perhaps in a more informed and incisive way about what and how things need to be done. Those are my initial thoughts. I don't think that contradicts what you've said, again. So thanks.
No, I completely agree. And I think focusing on the bit that we add and acknowledging that other stuff's going on, I think is a really useful way to go. So well done.
Thank you.
Monique, are you still? Yep, great. And then we'll come to the room.
Kia ora. Thank you, Simon. That was so good. It's so interesting and really chimes, I think, with Susie and I's sort of experience of talking with our young medical students in out on placement. I was really intrigued. I mean, you got some great commentary from the students there and quotations, and I just wanted to ask you a little more about what you how much you think it's a problem that ethics is sort of identified by the students as the thing you think about when it's not clear what to do. So in the Jehovah's Witness case, in that great quote from the student, they're like, well, it wasn't ethical because we could just give an iron infusion. So that young person wasn't seeing that was an ethical choice. I mean, their choice was to avoid the point of conflict or find something that incorporated all the goals. And I mean, this does worry me when I'm teaching, and I guess I fear that we make students feel like ethics is an impossible thing, by not noting the ways that you can do ethics really satisfactorily and easily and everyone feels good, not seeing that as ethics. I wonder how it changes some students' attitudes towards ethics.
Yeah. Again, thank you very much, Monique. I'm pleased to hear this aligns with what you guys are up to at Auckland and your experience talking to students and graduates. I agree with the thought, although I have a response, but there might be another take on it. So just philosophically, I do think of ethics as about problems. It's when there's an interruption. That's when we start talking. Most people don't bother with ethics, and they'd rather not. And so I'm not sure if we can get around that. I guess if we talk about values, then it's more of a front foot type thing. These are the things that, here's why we do what we do, and we're all enthusiastic about that. But again, that can maybe not land with some students. So quite often I find we have to persuade them that firstly there's a point. And usually we do that by telling a story of how something went wrong. But to me, it also brings up the importance of, or reiterates the importance of reflecting on practice, because most of us don't know how we're going to react in a given situation. And certainly if we think about the younger students, they just don't have the life experience to even imagine how they'll be affected in the situations that they're coming to. So we tell them these things are important, and they may or may not engage at an early stage. They might be intrigued by the stories they hear, but when they come into those situations, they need to have a chance to go, why did I respond in that way? And why is this much harder than I imagined it would be? Yeah, so those are my initial thoughts, but I think that is probably something we could spend more time thinking about. But in an ideal world, there wouldn't be an ethics class, because there'd be no need. We'd just do what we need to do. Yeah.
But we wouldn't be teaching medicine either, would we, Simon, in an
Well, I
ideal
suppose it depends how ideal our world is, yeah. Yeah.
I'm gonna put myself on the list now that you said that. Okay, Mike, Jingbao, are our next two in the room.
Thanks, Simon. Great talk. And Monique, pretty much covered my question, I think, which is I also think this is a problem. And I've sometimes heard this phrase as, so even though Monique has covered my question, I'm still gonna say it. Is that, bioethics is concerned with the sort of gray stuff, and the dilemmas is an interesting way into it. I think because with the dilemma, there's always something to regret with your choice. And so students can learn that there should be something regretful, or and that is the marker of the ethical content. And so therefore sort of overlook that when you don't have some of those features, you are doing ethics. And I think you're right, mostly.
Oh, sorry, I don't know what that is.
Yeah.
Proceed, Mike.
So, and you mentioned that it's good that people feel troubled about some of these problems. And I think I know what you mean. It's important that people identify situations that are wrong or something like that. But again, it's something that seems like it's these things are why physicians do it now.
Yeah.
Or one of the reasons why they do it. And so I sort of wonder about our having bioethics or the ethical decision making being a little bit more routine. It's less laborious, sort of labor, emotional labor wise and morally, and people can then feel good about also their work, their ethical work, even when they don't perhaps notice that they're doing it, because it's become something that's second nature to them. And that sort of thing, if we sort of cue them into, here's some ethics you're doing, and you can feel good about it. It takes some effort to think about why it's the right thing to do sometimes, and that's why we're going to cover it in class. Even though it might seem obvious to you, the reasons why it's obvious may not be so clear to you. And people recognizing that stuff is ethics may be a satisfying thing that they ought also to feel, which could help with it.
Well, yeah. As you say, it's a complex problem. There's probably other things as well to consider, but yeah. So what that translates to me is that we could be more celebratory in some classes. Isn't it wonderful that we figured this thing out.
Well, and sort of just pedestrian, you know, not, well, pedestrian, you know, like go through the things where this is why that's the right thing to do. Let's
Right.
not have the case where, oh, we're all not sure and who knows
Yeah.
where everything, you know, and all of
Yeah.
that. You know, why not have more cases where it's abundantly clear
That
and
could
we're
be, yeah.
settled on this?
Okay.
And what may not be so clear, in fact, to most people, what's not clear is exactly why we will settle on that and how perhaps we can for some different
Yeah.
value perspective.
Thanks, mate.
Jing Bell?
And minor comments. Oh, thanks. That's characteristically informative and insightful. And a minor comment is that the ethical witness comments. It's a good reminder about when we are doing our ethics teaching, emphasizing about the differences. We should not help reinforcing existing stereotypes such as cultural difference context can often come out.
Yeah.
My main question is, it's so stimulating here. It's how to conceptualize and the research, how to conceptualize and the ethical teaching overall. I wonder whether that the debate already going on, applied ethics versus practical ethics, and Aristotle's practical wisdom, Kant's idea of practical philosophy, reflect the idea of the converging ideas here too. I just wonder whether you can say that it's a practical ethics here. So here is really to empower future doctors as moral agents, in respecting patients as moral agents and their peers as moral agents, particularly from Kant's perspective.
Yeah. That's probably true. I'm not. Did you distinguish applied ethics and practical ethics?
Yeah, I think
I'm not familiar with that distinction, but I could talk to you about it later. But certainly, I am familiar with what you're picking up from Aristotle, and I think his whole model does fit nicely with where good doctors arrive at, because as I think Mike said, second nature. They just start doing what we need them to do, and what they understand is the right thing to do. They do it naturally without having to stop and think. I do think there is a lot to be said for that, and we could possibly make it more explicit in our teaching. Yeah. Oh, thank you, Shingo.
I've got 4 questions on my list. So I'm sorry, I don't know your name. Scott, and then me actually, and then Susan online, and then Janine. So we've got 12 minutes, so I think we can probably manage it.
So I'll just clarify and partially speaking on Val's question about the conceptualization. First thing that came to my mind was that it might be worth actually pushing against the whole dilemma-based approach and going from what's the right thing to do towards a more values-based. Because when you're looking at specific actions in specific circumstances, that sort of increases your variability. Whereas if you take a values-based approach, which then kind of leads into, there's actually, I feel, something far more fundamental in a cultural conceptual mismatch here. And we see it with changing within the law from this doctor knows best approach where, you know, a doctor is a all-knowing, all-knowledgeable monolith that has to have the weight of all their decisions on them, rather than what's sort of developing now, which is that informed patient model, which is more collaborative, integrated, communal, partnership-based decision-making, and that sort of fundamental conception of the doctor-patient relationship. And I wonder how much that plays into the sort of historical idea of how our medical professionals have been trained to more modern conceptions of including the patient and their family and other professionals as more of a collaborative, integrated part of the decision-making process. What really struck me about a lot of the quotes was that it seemed very isolated for most of for the new doctors. And coming back to what you said more about ethics is about fundamentally comes down to what it means to be human, be alive, and we've evolved to be social creatures. So if a young doctor is having to take the weight of these decisions upon themselves and not being able to collaboratively and integratively discuss them with other professionals and their peers. That's probably part of that conceptual mismatch. Two other things very quickly. The first is right when you were looking at the definition of what it means to be prepared. Our language, our words shape our worlds.
Yeah, sure.
And you used, a doctor who is prepared, recognizes challenges and has some means of negotiating circumstances. That negotiating, it's very singular, very zero sum. I would instead use the word navigating, because it's, these challenges are a journey as a group. And you've got to take along everyone who's involved with the circumstances. You've got to bring them along with you. Final point, and I find this when I'm training advocates and harm reduction volunteers and criminal reintegration staff for a NGO I work with. I'd ask that whether a lot of these questions and a lot of these challenges aren't actually to do with the ethical issue, but rather skillfulness around interpersonal effectiveness, which the DBT training on those modules would be quite good, or otherwise even looking at principled negotiation, such as the Harvard Negotiation Project. And how much of it is actually skills-based, the difficulty, rather than actually the ethics of it.
It's possible. I think those skills would be relevant in a lot of these situations and helpful. I don't think we escape the question for some of the situations. So, for example, I just one of the another example I didn't put up that occurs to me was a family member coming to one of the doctors and saying, so the patient was unconscious and probably dying. The family member requests, could we just do something to hurry things along? Now that needs some skill to respond to that question, but it also needs an understanding of what's lawful and what's the right thing to do. So that I wouldn't, I don't disagree that interpersonal skills, and I don't actually know DBT. Is that what you said?
Dialectical behavior.
Oh, yeah, well that takes a lot of teaching, right? I mean, learning.
Oh, no, it's all skills-based.
Okay. All right, anyways, I wouldn't say those things are not helpful, but I don't think they exclude the dimension of just thinking about why are we doing what we're doing, which is perhaps what I would say is distinctive.
It's just coming back to that intuition you mentioned a few times about a lot of the first and second doctors, they made that comment that they felt like they knew what the right answer was. It was just how to navigate everyone involved to get onto the same page.
Okay, thank you.
All right, I'm gonna ask my question, even though I'm on Team Everyday Dilemma, right? So I'm on the team on the Mike Monique team. Of
I see. Right,
lots of everyday stuff.
Okay,
where there's not like it's
not
not like unclear what to do.
Yeah.
And I think history is quite a useful tool.
Yeah.
Because we can point out that, like, a certain number of years ago, actually when I was in law school, I don't think it was clear that you could look at your own notes.
Yeah.
Because they belonged to the doctor. So things that seem really intuitive to the students, it's really helpful for them to understand a little bit about why that's not always been the case and stuff. So I think history is quite helpful. I just wanted to kind of, maybe it's a similar point to Scott's, but like this thing about how people gave the feedback in the study that they didn't feel like they could necessarily be the change that they thought they could identify. One thing I would say about that is that I don't think we're just preparing students for the first few years of medical school. I mean, of work. So sometimes you won't be able to be that person, and that's why it's quite fun, I think, sometimes to include in our case studies and stuff things like you are on a committee setting national standards because they're going to be doing this for decades, this work. And so that's some part of it as well. And I feel like it's okay, but I do take the point that maybe we can give them some more tools for what to do when they think there's something terrible going on, I can't act, but I just,
So that later point is something that I have considered. I had held on to that thought for a while. Recently, I heard one of the senior people in the med school describe our curriculum as preparing them for first and second degrees. The doctors who are with us might have a comment on this matter, but I'm inclined to agree, but I'm not sure how realistic it is. Perhaps we can discuss that.
And then I've got Susan online and then Janine in the room, and then we've only got 6 minutes.
Thank you very much, Josie.
Speak very quickly. Thank you, Simon. That was great. just coming back to one of your recommendations, you were thinking, and I agree with this, that it's better for students to be slightly troubled when they see things that are problematic and looking
Yeah.
like the guidance we
Yeah.
give them than oblivious. But I'm also very conscious of our responsibilities, not to help students learn as they hit the hidden and informal curriculums in ways that don't make them feel morally unsafe, because they know what they're meant to do, and it's practically very difficult to achieve it. So that wasn't to put you on the spot, but just to say an area that we're continuing to look at is teaching, because as you know, we had a lot of work on the new updated consensus statement on consent. First time I met with the year 5 cohort, they came and said, well, we're not doing the new consensus statement on consent. We're not getting the very specific consent where you say it would be advisable. So I'm just, thinking again about how we teach in ways that, build students' capacity and moral agency and don't make them feel vulnerable, like they're in the difficult position. And we do keep reiterating that these are holistic decisions, there's system constraints, etc. And you're not expected to do this by yourself, but just recognizing that heterogeneity.
Yeah, no, thank you. I do think it's an important point to raise, and I don't really have, I think you've articulated the point very well. And it would be quite unhelpful for us just to, tell them to go ahead and solve all the problems or be morally courageous and then find that we're setting up something that's impossible. But this is where, again, it's an integrated curriculum and we all need to be thinking about it.
Janine, you have the last question.
Thanks.
Actually, I'm going to start with acknowledging the ones that have come before, because they've overlapped a lot with what I was going to say about awareness and sensitivity. I think that we are setting the stage for the 40 or 50 years career rather than the first 2 years. But what if we are talking about the first 2 years? I'm thinking about a change in teaching that I made that I've been ambivalent about, and maybe I'm on the right track. In teaching pediatric ethics with 5th year ALM students, we went from giving lectures in a group to meeting with them while they're on their run for an hour, and I make them generate the cases. And if they don't generate a case of something, really shattering, I talk about, well, have you had to hold a baby down? Have you had to hold an older child down? When do you stop holding a child down? When do you decide it's not important enough to do it this time and that you can come back next time? And so things that are so everyday about restraining a child getting medical care, if they don't bring up something big, that's where I go. I was ambivalent. I was like, is this what I should be doing? But maybe it's exactly what I should be doing, because it may be more preparatory for their next 2 years. If we're preparing them for their next 2 years, that would probably be more preparatory than talking about how do you make a decision about a neonate with multiple congenital anomalies whose parents want to keep going when it's not possible, or something.
Yeah, I think it's a big question is, when do we expose students to potentially traumatic realities that they will have to confront eventually? Where do we? Yeah. I don't know.
Or the ones that they're already confronting.
Yes.
When do you hold, and you'll confront as a parent. When do I hold my child down and say you're doing this now? And when do you say, we could come back and do it later?
Yeah, good thought. Okay.
So thank you very much, Simon. I want to thank you on behalf of everybody. So let's give Simon a big round of applause.